Myself, I'm Ben. I'm one of the co-founders and the CEO of Astron Health. And Astron, I don't know how much background you've all got, but Astron is a translational multi-omic oncology company. And what that means is that we use this multi-omic analysis, so analysis of genes, but also of gene expression and protein pathways, to help us to translate scientific research directly into treatments that benefit patients. And the Polaris Report, which I'm going to take you through today, is key to how we do that. So the Polaris Report takes molecular test results as an input. Ideally, we get multi-omic data from a data report or a carriers test, especially good ones. And then we analyze that data to understand the disease drivers. Then, and this is a unique piece, we analyze over 170,000 published peer-reviewed studies to identify the best evident treatment options for each specific patient based on those multi-omic profiles. The analysis in the Polaris Report looks across the entire pharmacopoeia plus supplements. And so it's looking at all kinds of treatment options, could in fact even lifestyle interventions, diet, and so on. And it identifies therapies that can be used as adjuvant therapies, can be used alongside licensed cancer treatments. It also can be used in the curative setting after treatment cycles. So it's this huge range of new options, and it's used really to surface these well-evidenced options from across all available therapy types, not just standard of care drugs. So there's a huge amount of detail and research that goes behind these reports. They've reports run, I think, to over 100 pages. Sometimes if you really want to go into the detail, you can. But we've also made it super simple to read and understand and get the basics out of. And our aim is to give you and your clinicians the most in-depth, robust science, also to save your clinicians time, help them really focus their efforts on the most important parts of that research. So every treatment in this report is given an Astron score, and that score is a combination of multiple different factors. But essentially, it's a rating on how robust the scientific evidence is that that treatment may be effective for each patient. You've got three things that the report does that clinicians can't easily do on their own. So firstly, it identifies the best evidence repurposed therapies and adjuvants. It gives options to target additional pathways that standard of care may not be able to target for a more complete treatment strategy. And there's a lot of evidence if you're able to hit more target pathways of treatment, that's associated with better outcomes. So that's very important. Secondly, it finds options for patients for whom conventional precision oncology can't find a treatment. So Polaris helps the clinician to find actionable biology-aligned options. And then thirdly, it synthesizes the latest clinical evidence. So not only the mechanistic rationale for how treatment will work, but also the latest trial data, dosing, and puts those together, even like time of day of the intervention, of when you take the treatment, that can have an impact. And it puts that together in a format that's ready for clinical use. And so the result is this Polaris report. And it's really, you can think of it as a bridge that links this molecular testing to meaningful treatment options for many, many more patients than is otherwise possible. And that's what we're going to take you through today. We'll show you what your clinician is seeing and the depth of research behind it. And we'll also show you how they will be using that to make recommendations for you. So that's kind of introduction, with which I'll pass over to Sam, our Chief Scientific Officer, who can take you through the rest of it.
Excellent. Thank you, Ben. Thank you, everyone, for taking the time to join us to sort of walk through this. This is a development on our previous research report, and the priority is just to surface as much information as possible for clinicians to make their decision-making as accurate and as quick as possible, actually, to support their patients. And the way that we've done this is building, as Ben said, a really robust evidence base that is based upon scientific literature, essentially everything that's ever been published about cancer and all of the drugs that have been essentially attempted to be used to treat that. We've leveraged information around actually how those drugs at a molecular level interact with their targets in the context of cancer. So the genes that are mutated and driving cancer, the proteins that are made from those genes, and those genes interact with one another. And then also more broadly, actually, how heavily involved are those mutated genes or the proteins that are made from them? How heavily involved are they in a specific patient's cancer? And so the reason for that is to essentially find the best evidence, drugs that interact with those targets, to find the best targets to engage in order to try and improve patient outcome. Whether that's using FDA-approved drugs, so your sort of standard traditional chemotherapies, or precision drugs, or whether we're looking at repurposed drugs, so drugs that have been approved for use in sort of different diseases, or supplements and lifestyle choices. So what we're doing is essentially putting all of the information in a clinician's hands, which can be used in order to combat cancer. So yeah, we've got our patient Mary Jefferson here. She's got breast cancer. She's had molecular testing done, in this case by ductal. And from this, we've called 5 molecular vulnerabilities. And we'll go into those in a second. And through our analysis, we found that those molecular vulnerabilities, they interact in 14 different cancer-related pathways. Okay, so these are essentially 14 networks of targets that are essentially driving forward cancer development. And so in order to combat that, we've looked through our huge data set of all of these papers that have been published, of all of the experimental data that we have access to of these drugs interacting with their targets, 68,000 of these pairs. We've combined that with our knowledge of all of the different interactions between these targets. From that, for this patient, we found 69 therapeutic options, which should be and can be considered by clinicians. And we ranked them all, we scored them all in order to essentially support clinicians with not only having access to all of this data, but pointing them and signposting them to what would be the simplest, the most well-researched and most well-evidenced interventions that can be made. So what I'll do now is I'll walk you through the information that actually we're presenting to clinicians to support them with their decision-making. Please, at any point, stop me, ask questions. We're more than happy to go into a bit more detail here and there as is helpful or needed. So the first thing that a clinician will see is our sort of summary. And what this does is it breaks down the 4 most well-evidenced interventions that could be made on day one based upon the molecular vulnerabilities that have been identified, how important they are, once again, to the patient's cancer, to the evidence base underpinning those interventions, and to the evidence for that drug or that intervention essentially interacting directly with this target. And so when a clinician first opens up the Polaris Report, we said the first thing they'll see, in this case, they have a mutation in a gene, overexpression in a gene called ESR1. This is an estrogen receptor, so it's involved in sort of hormonal signaling, very common in breast cancer. And so the highest scoring intervention that can be made here is a drug called elacestrant, which is essentially it binds to this receptor in place of the hormone and then results in the receptor being broken down and slows down the growth of a tumor. And so at the very high level, the first thing the clinician sees is they see this Astron score, which helps them with ranking. And then they see this thing called the G score. That's how involved is this target in the patient's cancer, in its development, in its current growth. In this case, ESR1, this gene that we've mentioned, is very heavily implicated in the growth of this kind of breast cancer. They then see what we call the D score or drug score. This is essentially marks, is this drug sort of approved? Is it experimental? Has it been tested in cells in a Petri dish? Has it been tested in mice? Has it been tested in people? That's really an easy sort of flagpole for what kind of drug it is. In this case, it's called 100. That's because it has been approved by the Food and Drug Administration in the US. It's been approved for use by NICE in the NHS in the UK for this specific target. We then have our evidence score, which is based on that entire sort of corpus of evidence that we've managed to sort of access from the scientific literature. And then our binding score, which indicates actually, is there evidence for this drug directly interacting with the target? And then a simple summary. Okay, so this is the first thing clinicians see. And this really signposts to them, if we haven't already put a patient on one of these drugs, we can consider that early on because it's very well evidenced. And then you can also access sort of more information, and we'll scroll down to that in a moment, about each of these drugs by sort of clicking on these full target data sections. Or or clicking on any of these sections, the G score, D score, evidence score, binding score, to build up a full picture of what what each of these scores mean and how to understand them. So it's always as interpretable as possible. And then, a couple of other drugs here in the executive summary. So let's say our patient has just been diagnosed, they've just had molecular testing done, we found this ESL1 mutation, and we want to know more about what this drug is going to do for us, our specific patient. So we can go into our full target details. That brings us down to this second section. By target, essentially, this will highlight all of the possible targets for intervention in our specific patient. In this case, as we said, 5 mutations, there's 5 molecular alterations. And as we said, we'll talk about ESL1 first. And so, our clinician, they've probably heard of elacestrant, but they want to understand why it might be the right drug to use for a specific patient. And so in this section, we break down essentially what's behind each of those scores. And we provide clinician access to the evidence for the use of those specific drugs. So here we have essentially a breakdown of actually on a molecular level, what's this drug doing? How is it interacting with ESL1? And why is the Astron score as high as it is? We then have here sort of what is the gain of function mutation? So the molecular alteration that we've detected, what's it doing in the case of ESL1, alongside we have a target summary as well, explaining what ESL1 does. We have our evidence score, which here is sort of, can be very long if it's a drug that's not particularly well known. If there's a lot of literature about it, it can be quite short. In the case of this drug and this target, as we said, is well categorized. The D score, is it approved for use in this kind of cancer? Is it approved for use in a different kind of cancer and can be repurposed, or a different disease? And then the binding score, here we have that experimental evidence that supports direct engagement. And in order to back up all of this information, we also have a number of curated tools that will help a clinician if they want to better understand the research underpinning this drug target interaction. They can click out one of these. And in this case, this tool, 2 years ago, sort of explains the use of elacestrant in ER positive, negative metastatic. And we have essentially this level of detail, in many cases, even more detail, every single one of these drugs for ESL1. And then on top of that, we also go into that level of detail for every other target. So our approach at Astron is really focused on not only finding great treatment options, but supporting clinicians in targeting cancer from multiple angles. So rather than looking at individual mutations, we want to essentially provide options to hit sort of multiple targets which are involved in the development of cancer, to give it fewer options to mutate, fewer options to evolve, and fewer options to. And so here we also have overexpression of BCL2. Okay. And sort of another 6 treatment options. We can go into mTOR. We've got more treatment options down here, so on and so forth. But BCL2 is a good one to briefly go into, because here you'll see that these top 2 treatment options here, they're not FDA approved drugs. They're not tagged as such. They're lifestyle decisions that can be made by a given patient. They're incredibly low cost, and they're things that don't necessarily need to sort of fundamentally change the way you're living your life. They tend to be very low toxicity. They're more bearable. So in this case, caffeine is actually our best intervention for BCL2. And once again, we go into the evidence as to why why you might want to use caffeine. As we said, it's classified as a supplement. It's not regulated. You can just start drinking coffee. And sort of G score is as high as it is because BCL2 is really heavily involved in the development of this breast cancer. And while the evidence score is lower relative to these FDA approved drugs, because it's not been sort of tested and funded by big pharma to develop a robust evidence base, there is clinical data for the use of caffeine. And it has been indicated to be involved in pro-apoptotic effects, killing cancer cells. And so, as we said, it's an option that can be essentially taken alongside other treatments in order to support the sort of cancer-killing effects that can be seen with, we'll say, more traditional FDA-approved drugs. And likewise, vitamin D supplementation. And so through essentially all of these sections, your clinicians can build up, as we said, the most strongly, highly evidenced treatment plan they possibly can, without having to read through tens of thousands of papers, which no one in the world would have enough time to do. Such that essentially we're putting the right drugs at their fingertips that benefit patients based upon the person. The last thing that we sort of do is, it's not always going to be the case that there is an intervention which directly targets a gene. And for many patients, when they go and get molecular testing done, molecular testing may well return with a couple of molecular alterations for which it seems there are no treatments. And what we've done is we've taken into account a sort of, we'll say that the networks of genes that are involved in tumor development, whether that's inflammation, whether it's further development. And rather than just looking at ways that we can intervene on a specific gene, we also look at how we can intervene or target that gene based upon the other genes that it interacts with. Whether that's in a network, whether it's individual interaction partners. And TP53 in this case is an example of a gene that is present in, frankly, the majority of cancers, but there are no FDA-approved treatments for it. There are, as far as we're aware, essentially no drugs that specifically target it. And so what we do is this approach we call synthetic lethality, where when TP53 is mutated, it actually turns out that if you target some of its interaction partners, then you can essentially improve cancer. You can cause the death of cancer cells. And so here we provide not only those direct targeting, direct interaction pieces, we also look at synthetic lethality and membership. And in this case, we find that metformin actually in patients who have a TP53 mutation that results in that immunosuppressor that normally keeps cells healthy, no longer functioning. The use of metformin, which is a drug that's taken from diabetes, it supports with actually glucose metabolism and insulin signaling. So the way that your body processes sugar, the use of that result in a more positive outcome. Likewise, celecoxib, which it's this ETGS2 or COX2. In the case of TP53 mutation being present, you can result in more positive outcomes for patients. And so here, as well as providing that sort of core information that explains how this drug is interacting with its main target, we also provide this synthetic lethality evidence that explains why targeting the secondary gene or secondary mutation, in this case COX2, will result in more positive outcomes in patients who have a P53 mutation. And I think in brief, that's essentially what the Polaris report is, right? It's a way for clinicians to access all of the data that's available in a way that's already been processed, is already interpreted, and is ranked. That's that clinicians can essentially, as quickly as possible, without but resulting in sort of a lower quality, accessing lower quality evidence, but they can access evidence as quickly as possible that is accurate, that is very high quality, so that they can support patients in formulating treatment protocols as quickly as possible, so that you can engage cancer earlier and better. Now, as I said, I'm more than happy to take any questions, walk through anything in a bit more detail. There's a lot of information in there.
Yeah, thanks so much for this, Sam. There is so much detail, and you've done a good job on distilling that. I just wanted, actually, could you keep sharing your screen? Then?
Of course.
Yeah, I just wanted to give some of my understanding of this as well. And Pad, please jump in if I say anything that you think is not directly correct or put in the right way. Well, how I understand this is that each tumor has its own unique set of drivers. It's not like there's just one problem that's causing the tumor to grow and causing the cancer. And it's not, often we hear about people looking for a cure for cancer, like there's one thing that's going to do it. It's just not that kind of a problem. It's these complex, twisted knots of different pathways interacting with each other. And there's a lot of evidence that the more of those pathways that you can hit, the better the outcomes. And what this report does, the basic level, is it's here with the target. This is going from the genomic report, from that multi-omic data, the genomic report, the transcriptome. We're identifying which are the most important pathways, like which are the threads that are knotted in this cell. And that's something that you don't just get off the shelf from the genomic report. That requires more analysis. And then for each of those, we're looking across every possible treatment to identify what has the best evidence as hitting. And so what this does is it does a level of research that each individual clinician oncologist could potentially do if they had unlimited time. But it really would be unlimited time. I mean, as you say, looking across 170,000 research papers is probably not possible in a human lifetime. And yet this analysis allows them to get that benefit. We can then surface to them all of the backing they need to read to be confident that this really is a best recommendation. So I think that's the sort of way to think of it, is these targets, this shows in this patient's tumour, these are the pathways that are the sort of knotted threads that are causing the problem in the tumour. And then for each one of those, we've got the ranked treatments that are drawn from across really all of published science, and drawn from all across published science, and then ranked based on the quality of evidence for each of them. And that's at the core of what the Polaris report is.
Yeah, the thing I would add to that, I think that's a great explanation, Ben. The other thing I think I would say is that normally when you're sitting in a room and you have a patient who's had a molecular report done as a oncologist, what you're looking for really is the one or two genes for which you have a treatment that is licensed under the current guidelines. And beyond that, the rest of the report really isn't, you're not using it. But as Sam and Ben have said quite eloquently, there is an actual wealth of information there that unlocks our ability to understand what's driving the tumor at this present time. Our responsibility to our patients and public health really is not just to help untangle that and say, oh, it's very interesting, your disease is being driven by this pathway and that pathway. It's to also then say, well, look, drug development takes a long time. And yeah, absolutely, we might find targets where we say, we need new drugs that target this pathway, which we can't drug at the moment. But at the same time, we haven't got 15 years and $2 billion to create new drugs across every single pathway that we find. And that's why this matching process of identifying the right pathway in the right patient, but then finding the best interventions and having no philosophy of what that intervention needs to be. Sometimes it will be drugs. Sometimes it will be oncology drugs. Sometimes it will be repurposed drugs. Sometimes it will be supplements. Sometimes it will be, exercise training or caffeine or a ketogenic diet. Sometimes it might be, a combination of all of the above. But I think that's what's really important here. And certainly from my time in this world, dealing with patients like yourselves, what we're trying not to do is to have a one-size-fits-all protocol, because what I find is that patients often get a one-size-fits-all protocol from one clinician, and then they go somewhere else and maybe get another protocol and then somewhere else. And undoubtedly, many of those protocols will help a small percentage of patients, but they may not help the patient that we're dealing with in that moment. And I think that's why this precision and personalization is so required.